Assalamu alaikum students. Today's topic is hemoglobin. First of all, its definition. It is oxygen carrying conjugated red protein, the main constituent of red blood cells, concentrating hemoglobin up to 34 grams per 100 ml of cells. Hemoglobin molecule consists of heme, 4 pyrrole rings with iron in the center, that is heme, and the globin, that is composed of 4 polypeptide chains, 2 alpha and 2 beta chains. So heme plus globin becomes hemoglobin. Types of normal hemoglobin. Adult hemoglobin, it is of two types: hemoglobin A1, hemoglobin A2. Hemoglobin A1 has 2 alpha and 2 beta chains, while hemoglobin A2 has 2 alpha and 2 delta chains. Fetal hemoglobin is also normal. It has 2 alpha and 2 gamma chains, and embryonic hemoglobin as well. It is of two types: Grover 1 and Grover 2. Grover 1 has 2 zeta and 2 epsilon chains, while Grover 2 has 2 alpha and 2 epsilon chains. So these are the physiological types of hemoglobin, that is mainly of three types: adult, fetal and embryonic. Types of abnormal hemoglobin. Hemoglobin S, this type of hemoglobin is present in sickle cell disease. Hemoglobin C, this type of hemoglobin does not carry oxygen well. Hemoglobin E, this type reduced synthesis of beta chains may cause beta thalassemia. Hemoglobin D, this type of hemoglobin is present in sickle cell disorder. And hemoglobin H, that is heavy hemoglobin. This type of hemoglobin may be present in certain types of thalassemia. So these are the abnormal types of hemoglobin. Functions of hemoglobin: transport of oxygen from lungs to tissues. In males, 21 ml of oxygen carried by 100 ml of blood containing 16 gram of hemoglobin, while in females 19 ml oxygen carried by 100 ml of blood containing 14 grams of hemoglobin. As you know, in males there is more hemoglobin as compared to females. And there is a transport of carbon dioxide from tissues to lungs, and regulation of blood flow, and acts as an intracellular buffer. So these are the functions, very important functions of hemoglobin. Normal ranges or values of hemoglobin. The normal range in adult male is 13 to 16 grams per deciliter or gram percent, while in females, adult females, the range of hemoglobin is 12 to 14 gram per deciliter or gram percent. So here is the formation of hemoglobin. You can see here the 2 succinyl CoA plus 2 glycine form pyrrole, and 4 pyrrole combine to form protoporphyrin 9. And this protoporphyrin 9, when combines with iron, it gives heme. And this heme, when combines with polypeptide, it gives hemoglobin chain alpha or beta. So 2 alpha chains and 2 beta chains will give hemoglobin A, that is hemoglobin A1. So 4 pyrrole rings combine to form protoporphyrin 9, which combines with iron to give heme, and this heme then combines with globin or polypeptide to give hemoglobin. So it is about the formation of hemoglobin. So here is the breakdown of hemoglobin. When the red blood cell reaches its maximum life, that is 120 days, then the RBCs undergo lysis. And when there is lysis of lysis of RBCs, hemoglobin is released from the RBCs, and when hemoglobin is released from the RBCs, it undergoes degradation. So the degradation of hemoglobin degrades into globin and heme. So globin part, that is the protein part, enters the amino acid pool or in the protein reserves, while this heme is divided into iron, and the remaining part is converted into biliverdin and then bilirubin, which is excreted in bile, while iron is stored in liver in ferritin form, which can be reused in the hemoglobin synthesis. So this is all about the breakdown of hemoglobin or degradation of hemoglobin. So it is another diagram from Guyton where you can see the hemoglobin red cells is the degraded hemoglobin is converted into bilirubin, into free iron by the macrophages, while the hemoglobin red blood cells, the blood is also lost in daily menses, that is, and the iron part is 0.7 milligrams, and the iron is absorbed from the small intestine, and there iron binds with transferrin, and there is the free iron binds with is in the form of ferritin, which are the store form of iron, and from this iron there is a synthesis of heme and hemosiderin as well, and the iron is also excreted about 0.6 milligrams daily. So in plasma, iron binds with transferrin, while in tissues, iron is in free form as well as it is mainly in stored form, that is ferritin. So there is interconversion between ferritin and free form. So the amount of iron which is required by the body is in free form, and which comes from the stored part of iron, that is ferritin. So regarding the clinical significance of hemoglobin, the causes of higher hemoglobin level, that is in polycythemia, where there is increase in red blood cell count, the physiological causes are intrauterine life 1 to 9 months and newborns, first 28 days of birth, and this is due to the intrauterine hypoxia, because the intrauterine hypoxia causes erythropoiesis, while in males testosterone enhances erythropoiesis. High altitude hypoxia also causes erythropoiesis. Exercise also induces hypoxia, and due to increased oxygen demand by the body, there is again increased erythropoiesis, and when there is increased erythropoiesis, there is increased hemoglobin levels, while in pathological causes of increased hemoglobin, there is polycythemia vera. The polycythemia vera is the raised RBC count due to pathological reasons, including kidney tumors due to increased erythropoietin production, and systemic diseases like chronic obstructive pulmonary disease and congenital heart diseases. While the dehydration causes relative polycythemia, because when there is a decrease in blood volume, there is relative increase in RBC count. For example, in burns, in diarrhea. So this dehydration also causes relative polycythemia, which causes increased hemoglobin levels. While regarding the causes of a lower hemoglobin level, the physiological causes include females. As you know, the estrogen reduces erythropoiesis in pregnancy due to hemodilution by increased plasma proteins and decreased RBCs production because of raised estrogen levels. So there is a two-way reduction in RBC count in pregnancy, one by hemodilution and other by decreased RBC production by raised estrogen levels. And the third cause is menstruation, loss of blood during menses, and old age due to decrease in androgen levels. There is a decreased erythropoiesis and there is decreased hemoglobin level. And while the pathological causes include all types of anemia and thalassemia, so in conclusion, the reasons behind increased erythropoiesis are the same for increased hemoglobin levels, while the reasons behind decreased RBC count are the same for decreased hemoglobin levels, because the hemoglobin is present in RBCs. So both have a direct or direct relationship. If the RBCs increase, hemoglobin increase. If the RBCs decrease, hemoglobin is decreased. What are the hemoglobinopathies? A group of inherited disorders characterized by structural variations of the hemoglobin molecule. There are disorders of globin synthesis rather than heme synthesis. So it is a group of inherited disorders, hemoglobinopathies. These may result from synthesis of abnormal hemoglobin, reduced rate of synthesis of normal alpha or beta globin chains, and genetic defects of hemoglobin are the most common genetic disorders worldwide, which includes thalassemia, autosomal recessive inherited disorder characterized by abnormal hemoglobin due to mutation in the DNA of hemoglobin producing cells, types alpha thalassemia, beta thalassemia. These are the target cells in the thalassemia. Alpha thalassemia occur in fetal life. Alpha chains are less absent or abnormal, and the genetic defect at chromosome 16. Beta chains are in excess in adults. Gamma chains are excess in children. Defective hemoglobin and hemolysis is there. Beta thalassemia. In beta thalassemia, the beta chains are less in number, absent or abnormal, and the defect is at chromosome 11. Excess of alpha chains precipitate during erythropoiesis. Symptoms: there are two types of thalassemia, thalassemia major and minor. In thalassemia major, there are bone deformities in the face in children, while in infants there occurs a stillbirth. In children there is a yellowishness of the skin, that is jaundice, fatigue, growth failure, shortness of breath, while with the thalassemia minor there are no symptoms. So these thalassemic patients have a very specific phase called thalassemic phases. You can see in the diagram. You can see also here thalassemic phases. So the clinical presentation: shortage of red blood cells, anemia, pale skin, weakness, fatigue, hepatosplenomegaly, that is enlarged liver and spleen. And while the beta globin chains are capable of producing soluble tetramers, and this form of hemoglobin is still unstable and precipitate within the cell, forming insoluble inclusions called Haynes bodies. These Haynes bodies damage the red blood cells. This further results in damage to erythrocyte precursors and ineffective erythropoiesis in the bone marrow. hypochromia, and microcytosis of circulating red blood cells. Two types of thalassemia, major and minor. Thalassemia major is the severe form, while thalassemia minor is the mild form. In thalassemia major, there is presence of two abnormal genes, while in thalassemia minor, one gene is normal and the other one is mutated. It is the thalassemic inheritance pattern, as it is the autosomal recessive, so one offspring is affected and the two are thalassemic trait or the carriers. Dark urine, abnormal facial bones and poor growth, poor appetite. Adolescents with severe form of beta thalassemia may experience delayed puberty are also the clinical presentations. So regarding sickle cell anemia, inherited blood disorder, sickle shaped RBCs, abnormal S hemoglobin, alpha chains are normal, beta chains are abnormal, S hemoglobin polymerizes and precipitates, bones in X-rays have sawtooth appearance. Sickle cell disease inheritance is also homozygous, is also autosomal recessive, and you can see here the homozygous recessive offspring is affected. While sickle cell anemia, when this hemoglobin is exposed to low concentration of oxygen, it precipitates into long crystals inside RBCs. The precipitated hemoglobin damages cell membrane and give red blood cells a sickle appearance, highly fragile, leading to serious anemia. Such patients experience a vicious cycle of events called sickle cell disease or crisis, because in low tension there is more sickling and rupturing of red blood cells, which results in further reduction in oxygen tension, and this further reduction in oxygen tension still increases more sickling and red cell destruction. So it is a vicious cycle. Sickle cell acute chest syndrome, acute chest pain with fever is a common complication of sickle cell disease. Pulmonary opacities are frequently seen on chest X-ray, while empirical antibiotics and supportive pain therapy are the treatment options for acute chest syndrome in sickle cell disease. This is the morphological picture of sickling of red blood cells. This is again sickling, and again another picture of sickle shaped red blood cells. So thank you. If you have any query regarding hemoglobin, you can contact me, and you can see the thalassemia and sickle cell anemia are the types of hemoglobinopathies, which we have also studied in the topic of anemia as well.